again, thank you for joining us tonight. My name is Bill Soloway, and I'm the president of TRIO Philadelphia chapter. That's Transplant Recipients International organization. And here it is, our October 2021 meeting tonight. We're still virtual. And tonight we have a special program, which I believe is timely for us. We have two individuals joining us from the Jefferson Transplant Institute here in Philadelphia, Pennsylvania. The Jefferson Institute program includes advanced heart failure and transplant center, kidney transplant, liver transplant, and pancreas transplant. So our topic of discussion tonight is Medicare open enrollment plans, Medicare and ACA open enrollment. Medicare enrollment started, I believe, on October 15th, and the ACA is on November 1st. So we're going to hear from our speakers. We have Juliet Gall, who is the operations manager and has worked with Jefferson Transplant for 7 years and worked in the scheduling, finance, and operation teams. Juliet is passionate about helping guide patients through the transplant process, from evaluation to listening to transplant and finally post-transplant care. And we're also lucky to have Brenda Davis, who is the lead transplant financial coordinator at the Jefferson Transplant Institute. Brenda is celebrating 14 years this month with Jefferson, but she's been in transplant for 22 years. She never imagined being in transplant for as long as she has, but Brenda has a heart for helping people and helping them navigate through this difficult process of insurance. It's completely overwhelming, as we all know. And when you add transplant to the mix, Brenda enjoys the sigh of relief patients feel after consultation with them. And Brenda and her team feel very appreciated when they are able to assist and help the uninsured patients that come to the Jefferson Transplant Institute. So with that, I want to welcome both Juliet and Brenda. We are looking forward to you explaining this pretty tricky and sometimes hard to navigate. I'm always going, do I have the right insurance? Do I have the right coverage? There's so many different options, and the way healthcare changes as frequently as it does, a lot of us just go, oh, I'm just going to keep with what I'm doing. And we're probably spending more money than we need to be at times, or maybe not even getting the necessary coverage. So we're going to call on Brenda first here to kind of walk us through the process, and then we'll have Juliet follow up, and then we'll have some time to answer questions. So with that, I want to turn things over to Brenda, and welcome.
Thank you so much, Bill, for that introduction, and thank you all for taking a little bit of time out of your busy schedule this evening to talk with Juliet and me. We are very honored to be presenting to you this evening. I'm actually going to start sharing my screen so that you all can view the slides. Can you see that?
Yes.
Awesome.
And if you could go, maybe
I'm just going to present. I'm sorry.
Maybe if you can go to full screen. So click on that little screen at the bottom right-hand corner next to the 130%.
Yeah. 1 second. There we go.
Yeah, so see where it says 130%? There's a little screen to the left of that. Click on that. So just, there you go. That's it.
Awesome.
Perfect.
Okay. Great. Okay. Juliet and I want to speak to you tonight about the financial role of transplant before, during, and after. Medicare is not an exact science, and it's not a benefit that everyone is entitled to. Entitlement to Medicare is actually based on your work history. You earn up to 40 units per year in order to qualify for the benefit, a total of 40 units in total. as a minimum to qualify for the Medicare benefit. So each quarter, you actually earn 1 unit. That's one unit per quarter, 4 units per year, and that's based on full-time employment. So it really takes a total of 10 years to accumulate enough units to qualify for the Medicare benefit. If you happen to be a part-time worker, it just takes twice as long. Part-timers is going to take a good 20 years to accumulate the number of units required to qualify for the Medicare benefit. But the actual eligibility is always determined by the Social Security Department. Some important dates regarding transplant patients and Medicare recipients. As Bill alluded to earlier, this is currently the open enrollment period for Medicare recipients who are already on Medicare. You actually have to have both A and B during this period to make any changes to your plan, whether it's to add or drop a supplemental or Medigap plan, or to switch your Part D drug plan, or even choose a replacement or an Advantage plan. Those two terms are used interchangeably, Advantage and replacement plans. This is that period when you can make those changes to your plan. It's often good to go onto the website and you can compare up to 3 different plans to make a decision, make the best decision for yourself so that you choose something that's going to be comprehensive for yourself in the incoming year. And you have an opportunity to make these changes every single year during this time frame. Again, that open enrollment for this period started October 15th. It runs through December 7th, and whatever changes you make to your plan will become effective on January 1st. So just make sure it's something you actually want to do. Now, if the new year comes and you haven't had an opportunity to use your plan, you literally have until the end of March to figure out whether or not what you chose is appropriate for you, is accepted by your current providers. So you have until March 31st to make a decision whether or not you want to maintain whatever change you made for the new year. Okay, now if you decide to discontinue what you chose for that new year, you actually fall back to whatever insurance you had the previous year. You're not allowed to make another change during this time frame. Now, the general enrollment period that begins January 1st and runs through March 31st every year, that's the period for people who are entitled to Medicare, but did not enroll into either A or B for whatever reason. This is the opportunity that every Medicare recipient can pick up either A or B, A and or B during the general enrollment. Again, it starts January 1, runs through March 31st every year, but whatever changes you make during this period does not take effect until July 1st. There are certain times of the year where people can actually add or drop Medicare A and B at the same time, but you have to qualify for what's called a SEP or special enrollment period. That's when someone is employed and lose active employer group insurance and have an opportunity to pick up Medicare. If a spouse who carried the coverage for you expires, you have an opportunity to enroll into Medicare A and B. If you relocate and your Advantage plan is no longer accepted where you're moving to, that qualifies you as well to enroll into Medicare A and or B outside of the general enrollment or the current Medicare open enrollment. If you're new to Medicare, you've never had Medicare and you're entitled to, for whatever reason, you actually have 6 months once you become Medicare eligible to make any changes that you want to make, whether it's to add a Medigap plan, choose a Part D, or choose an Advantage plan. Again, a 6-month period once you're brand new to Medicare gives you time to make any decisions you need to make for yourself. There are different reasons for being entitled to Medicare if you're not of Medicare age, meaning normal retirement, age 65 to 67, depending on when you were actually born. For kidney patients, those are some of the patients who are actually entitled to Medicare sooner than later. ESRD dialysis will entitle them to have Medicare within the first or fourth month of dialysis, depending on the type. Peritoneal dialysis are usually the ones who do the dialysis at home. Your Medicare entitlement begins the first day or the first month of the first day of the first month that you actually start PD dialysis. But those who actually have to physically go to the unit a few days a week for hemodialysis, that Medicare entitlement begins month 4 of hemodialysis. Even if that first day is the last day of the month, that entire month counts as the first month of entitlement for ESRD hemodialysis patients. The difference with ESRD entitlement to Medicare and other disabilities or normal entitlement is that entitlement to Medicare is temporary. If you qualify for the benefit, you're entitled to that Medicare the entire time you're on dialysis, and the clock for the 3-year expiration date does not start until the month you actually receive the transplant. So if your Medicare was based on ESRD dialysis alone, 3 years after a successful transplant, kidney transplant, Medicare entitlement goes away unless you are of normal entitlement age at the end of your 3 years, or you have another disability other than the ESRD or kidney transplant that will entitle you to maintain that benefit. There are lots of other people also who have a disability before they start dialysis. So their reason for Medicare or the entitlement reason changes from from disability to ESRD Medicare. And there's another process, either your institute social worker or the dialysis social worker will assist patients through. But again, if you're entitled to the transplant based on age or normal entitlement, the 3 years after a kidney transplant, your Medicare would not go away. Oh, I'm a little bit ahead of myself again. Once you reach legal retirement, you have the opportunity to enroll into Medicare A and B, and again, Social Security will determine whether or not you have enough of those work units to actually qualify for the benefit. Now, even though you turn 65 and you may not be working any longer, if you have a spouse who is still actively working, you can opt out of the Medicare Part B. Medicare Part A is the benefit you've paid into that Social Security tax throughout the years, so that does not come with a monthly premium. Medicare B, for whatever reason, comes with a monthly premium, and that monthly premium is going to be based on the income that you have acquired throughout every year. For most people whose income is less than approximately, I think it's $80,000 a year, the Medicare Part B monthly premium is now $148. It was $144 for quite some time, but it bumped to $148, I believe, last year, 2020, January. But for people whose income is beyond the $80,000 per year, the Medicare B premium will fluctuate significantly. And honestly, it's a few $100s for a lot of those people. So many of them will opt out of the B until it's necessary for them to pick it up. And as long as that Medicare recipient or the spouse is still actively working, you have the opportunity to opt out of B. Now, there are some employers who actually still offer a retirement benefit to their employees beyond their working stage, and that usually will coordinate very well with the Medicare A and B. So everyone's encouraged to always check with their HR department to find out what benefits they can carry with them after they stop working. And that will eliminate the need to apply for a supplemental insurance. And it's usually a lot more cost effective as well. Now, many people don't realize that there's a penalty for not choosing A or B when you really should. And it doesn't include the people who choose not to get the Medicare A or B because they have an active spouse who's working. This usually comes into play when people have employer groups who offer a benefit to them, the regular benefits to them beyond retirement for a period of time. I know that many governmental employees or I think some SEPTA employees years ago, you were allowed to carry a benefit for up to 5 years after you retire. However, many of those patients should have been instructed to still apply for the Medicare A and B, because even though you're carrying your benefit for a period of time after you leave your work, the fact that it's not active employer group will cause you to be penalized for not choosing the Medicare A and B at the time of retirement, not at the end of the extended benefit. And patients usually aren't counseled by their HR department. They don't know what questions to ask, and you don't know what you don't know until you run into a period of time where your insurance is not covering, or Medicare penalizes you for not choosing that benefit when you should. And the penalty is 10% of your monthly premium. So if your monthly premium is $148 now, you're attaching another $14.80 to your premium. And that is continuous. It doesn't go away. So it doesn't benefit patients to be underinformed about when to choose Medicare A and or B. For the ESRD patients, kidney patients, their COB period is a little bit different. They don't have the luxury of waiting for someone to lose work and to pick up the Medicare A and B. They have to do it before their Medicare becomes primary. When you start dialysis, there's a 30-month period to where you're entitled to the Medicare, but it is definitely secondary for the first 30 months. And after that 30-month period is satisfied, it's critical for patients to know that they need to have that Medicare benefit on file, but they also need to know when to pick it up, because Medicare no longer allows you to pick up the Medicare at the end of that COB period. It's really important for transplant staff and dialysis staffers to educate the patient on when to pick up the Medicare in time. So at the end of that COB period, the Medicare is on file when the order switches. We run into lots of patients who choose not to pick it up, or they're not educated timely, and they're paying the price for that. So it's really important to maintain a relationship with your transplant staff, and if you're on dialysis, with your dialysis social worker. Okay, disability and enrollment entitlement, again, is determined by Social Security, and the order in which who is primary is based on active employer group, again, from either the Medicare recipient or the spouse. And as I mentioned before, if a patient loses coverage through the employer group, it's another opportunity for them to pick up the Medicare. One other thing that patients don't realize is when you leave your job and they offer you COBRA, that's great because many people want to maintain the benefit that they had while they were actively working. However, if you are entitled to the Medicare benefit, it's really important, again, to reach out to the transplant financial coordinator or social worker, or the dialysis social worker, if that's your case, because COBRA is temporary benefit. So I would always recommend Medicare in a supplement as opposed to COBRA, because first, it's limited. It's only guaranteed for the first 18 months, and I think it's been shortened since right before COBRA. That time frame was shortened. Don't know the exact time frame, but 18 months was the benefit period for COBRA, and certain disabilities would allow an 11-month extension. So the total time frame that a patient could have a COBRA benefit would be 29 months. However, at the end of COBRA, you're not allowed to pick up the Medicare at that time unless it's during the general open enrollment period, because the government does not consider COBRA as credible coverage. It's benefits carried after work, but it's not active employer group. So at the end of that benefit, you are not allowed to pick up the Medicare. And it is leaving some patients underinsured or uninsured for a period of time. And we never want that, because we never want a patient to not have access to medicines. And they're, of course, they're providers of care. I know there are going to be lots of questions about this one at the end of the presentation, but that's fine. Okay, did I go backwards? Okay, Juliet?
This is your last slide, Brenda.
Oh, okay, we split them up. This is a repeat of what I mentioned earlier. I have documented earlier, Medicare begins on the fourth month of hemodialysis, first month of peritoneal dialysis. And again, this is specific to ESRD dialysis patients. The Social Security Department will assess the patient for the Medicare entitlement. The social worker at either the transplant unit or the dialysis unit will initiate the paperwork that the patient will have to present to Social Security, but Social Security does the actual assessment. Once they are eligible for that Medicare, again, Medicare is definitely secondary for the first 30 months, unless the other insurance that that recipient has is Medicaid. Medicaid is always going to be the last payer, no matter how many insurances you have on file. Okay.
Thanks, Brenda. Okay, so as Brenda was touching on before, that 30-month period is actually called the Coordination of Benefits, or COB for short. And that begins on the first month of Medicare eligibility, not the month that dialysis begins. So it's usually that 4th month into dialysis. Patients have the option to opt out of Medicare if the active employer group's on file, and if Medicare is the secondary payer. However, they must have Medicare in place by the end of that 30-month COB period. Again, some of this is stuff that Brenda touched upon before. Medicare becomes the primary payer and the employer group benefit becomes the secondary. The employer group benefits have the right to pay as secondary payer, whether or not the patient actually enrolls into Medicare A and B at the time of the COB period. So this is why I know Jefferson, as a transplant center, definitely educates all of their patients. Make sure you pick up that Medicare A and B before the end of your COB, because if you don't, then the patient might be left with an employer group coverage that's saying they're only now going to pay 20% because they know that you should have Medicare as your primary. Should a patient not enroll into Medicare by the end of the COB period, he or she is then underinsured or no longer eligible for transplant. Live donors also can't be considered until the patient has sufficient coverage for transplant. Medicare will end 36 months after successful kidney transplant. Brenda mentioned this earlier, that 3 years after transplant, as long as there's no other disability that would entitle you to Medicare, or if the patient is 65 years of age at the end of that 3 years. So should the patient become entitled to Medicare again, whether they are on dialysis again, finding that they need another kidney transplant, they're diagnosed with another qualifying disability, or again, they're at that current legal retirement age. So here are some important dates. Some of this is summarizing what we talked about before, but just to make sure everybody knows, there is that 30-month COB period once you become Medicare entitled or eligible for Medicare, whether you enroll into Medicare through Social Security or not. Medicare will be secondary to any employer group health plan for the first 30 months. Once that period's over, that's when Medicare doesn't inquire themselves to determine whether or not they should be the primary payer or the secondary payer. Your insurance could penalize you for not choosing Medicare when you become entitled, and can reduce or deny payment for services related to your kidney disease. So just more on other disabilities other than the ESRD entitlement. It's the same as mentioned above. The difference is when a patient actually becomes eligible for that Medicare benefit. Once a patient is approved for disability, there's actually a 2-year waiting period for Medicare eligibility. So in that 2-year period, the patient does still need insurance through other sources until they actually can get that Medicare. Once the Medicare is effective, it can be primary or secondary, depending on the type of coverage that's on file. For example, that employer group, Medicaid, marketplace plan, which we'll talk about in a second, or COBRA. Okay, I'm switching gears for a second. This New Jersey PAD Senior Gold and then Pennsylvania Chronic Renal. These are pharmaceutical assistance programs for New Jersey and Pennsylvania. The Senior Gold and PAD are for New Jersey, Chronic Renal for Pennsylvania. You can check with your transplant facility social worker or financial coordinator to find the exact eligibility in your state. We mainly have New Jersey and Pennsylvania patients, so we were focusing on that for this presentation, but there certainly are other states that offer types of assistance. These programs will help with immunosuppressant medications after transplant. So Medicare pays that first 80%, and then these programs will help with that other 20%. New Jersey PAD usually and chronic renal, it could be as low as $6, $8 for your medications. Senior Gold is a little bit less assistance. It's usually a percentage of that 20% that's left, but it still significantly reduces your copay for your medications. The PAD and Senior Gold cover any medication, so it's not just your transplant meds. And then the chronic renal covers any renal medications. All right, so the Affordable Care Act, ACA, Obamacare, you'll hear it a bunch of different ways. It's all the same thing. It's actually a private insurance that's available to people who are not yet eligible for Medicare. And you also have to be over income for state Medicaid. So each state requires you to apply for Medicaid first. You actually have to get that Medicaid denial to then be eligible for an ACA plan. Most people are also eligible for assistance with the monthly premiums that come with ACA plans. Again, that's based on income. The premiums can be subsidized by the government if you meet those income requirements. The open enrollment for ACA starts on November 1st. For Pennsylvania and Delaware, it ends on January 15th. And for New Jersey and New York, it goes until January 31st. There's a whole list of, each state has their own dates. It's around the same time frame for each state, but it does vary. Regardless on state, you do have to enroll in an ACA plan by December 15th if you want it to begin on January 1st of 2022. Monthly premiums, they have to be paid timely in order to maintain the active coverage. If you don't maintain them, it will become inactive. And you actually are allowed to shop around annually for a plan. So if you have an ACA plan this year that you didn't exactly like, there's plenty of ACA plans out there. You can look around, you can pick a different one for the next year. All right, a little bit about Medicare and the ACA. So you can actually have both. However, if you are receiving assistance with your ACA monthly premium, so you qualified for a government subsidy on that premium, you may actually lose that subsidy that offsets the premiums once you have the Medicare. Should you become Medicare eligible, you are encouraged to reach out to your financial coordinator or social worker at your transplant center for guidance on this so that you have the best coverage possible. And that's the end of our slides. Do you have any questions for us?
Well, thank you both, Brenda and Juliet. Obviously, a lot of discussion about kidney. I would imagine there's pretty close similarities for heart, liver, pancreas, the other organs that you transplant there at Jefferson. I got to tell you, I was glad when I went into congestive heart failure prior to my heart transplant that a good friend of mine said, we need to get you on disability. And, I didn't think that I needed it. I was in that river that runs in Egypt called denial. And I was glad someone opened my eyes to making sure that I had applied for disability. So I'm thankful for
Absolutely.
that. When we talk about,
yeah, that's good.
Yeah.
Go ahead. I'm sorry.
When we talk about some of these
You had
other
somebody to
organs,
help you.
yeah. When we talk about some of these other organs, Brenda, like heart and liver and pancreas, what are some of the differences or similarities?
The biggest similarity with those organs is that once you're deemed disabled by Social Security, there's no threat to losing that disability benefit. The disability doesn't end. There's no expiration date on that. And that's why it's just one blanketed set of rules. Once you're disabled, the biggest drawback is the waiting period to be eligible for the Medicare. That was the biggest drawback for so many people. I mean, we turned away quite a few people years ago because there was no access to any coverage at all. And I guess that's the biggest thing. The biggest difference is that there's no expiration date on your disability.
Okay. Do me a favor and hit end on your slideshow so we can then take back, or if we can stop share screen so we can go into a full screen with everybody.
While she's doing that, one of the things we actually didn't touch upon, Brenda, is about whether you have Medicare at the time of transplant or if you get it afterwards. Depends, and I'm going to pass it back to Brenda after this. She'll explain it much better than me, but depending on if you have it at the time of transplant or after, what part of Medicare is actually going to pay for those immunosuppressants changes between Part B and Part D.
Okay, yeah, totally forgot about that. Yeah. Let me just get out of this. There we go. Depending on whether or not you had either Medicare A or B at the time of transplant determines who's going to be responsible for your anti-rejection meds. Even though Part B is responsible for the anti-rejection meds, if you have Part A at the time of transplant and pick up B later, whenever you pick up B, B automatically is responsible for the first 80%. However, if you did not have A or B at the time of your transplant and it was paid for by a commercial plan or Medicaid, then all of your meds, including your anti-rejection meds, are processed through your Part D drug plan whenever you pick that up. So it really depends on whether or not you had active A or B at the time of transplant. That determines who pays for your medicines.
Brenda, what's some of the common things that you see? Most of us are seasoned transplant recipients. We're not, just a year out or so. What are some of the common things that you see in changes that maybe we could benefit from based on your experience? In switching plans.
Honestly, it's always changing.
Yeah.
Always changing. Remember years ago when the Advantage plans first became available, we literally referred to them as disadvantage plans because there was no real advantage to the actual recipient. It was just money being drawn out. The copays were the highest I've seen in comparison to commercial plans and of course Medicaid. Most of the drugs were never covered. So they've gotten much, much better over the years, but for years we literally refer to them as disadvantage plans. And we strongly encourage patients when they come in for evaluation in the beginning, strongly encourage them to stay away from those. This time of year is really aggravating for me because of all the commercials, selling you all the happy faces about Advantage plans. They don't tell you about all the other costs that's associated with it, with bundling everything together. You don't never get to see the smoke screen until you go to use the benefit in the new year, which is why Medicare now allows you to go back to what you had previously. The cutoff for that used to be February 14th. You had 6 weeks to figure out whether you wanted to maintain this new plan that you chose. But because of all the problems with people not having time to actually utilize the benefit and not knowing whether or not it's really working for them, they've extended that period. So now you have until the end of March to drop that new plan that you chose and go back to what you had before. The biggest issue with that is people choose Advantage plans because they either can't afford a supplemental, and years ago, they weren't qualified for supplemental plans. Many of the applications would have questions like, do you have liver disease? Or are you on dialysis? And it allows insurance companies to not offer a plan or charge such a premium so it was not affordable for patients to supplement that Medicare. And that was the whole idea of the Advantage plan in the first place, but they were not advantageous to many recipients back then. They've gotten much better. With premiums are lower. They're covering more and more drugs every year. And the co-pays for certain services like specialist office visits and inpatient stay are getting lower.
Mm-hmm. Brenda, just to add your personal experience to that, my wife has a supplemental plan. I have an Advantage plan. I pay no premiums. She pays premiums. My co-pays are offset by not paying premiums. And at this particular point, we are very detailed in tracking our expenses. And 10 months into the year, both of us have had major surgeries. We are exactly the same expense overall, including the Medicare payments, the premiums, the co-pays, the drugs. We're within $10 of each other. It's amazing. So yes, they have improved considerably over the years, and I'm finding my Advantage plan works very well, as she is very happy with her.
Supplemental. That's
Just
great.
throw something in there for you.
That's good to hear.
One of the things I've heard about the Advantage plans that sounds like a negative to me is you have to use in-network physicians. And I live up in the Allentown area of Pennsylvania, and I go down to University of Pennsylvania for my transplant team. And those doctors, I would think, would be considered out of network.
Yeah, when you go into Advantage plans, they're only allowed in the area in which they're offered. There are counties within each servicing area, and they expect you to stay within the servicing within that area, and not unlike traditional Medicare. Traditional Medicare you can carry throughout the state wherever you want to go. But when it comes to the Advantage plan and especially HMOs, that's when the restrictions are imposed, and you have to stay within a servicing network. Although there's a large network of facilities and doctors in each plan, you've established a relationship already with the providers that you currently have, and you don't want to let that go. And that's something you definitely will lose when you go to the Advantage plan.
Well, to add to that also, Brenda, I think those of us who are down near Philadelphia, I'm over in New Jersey, but I've always been with Penn, and I have been using Virtua more recently, and that Advantage program has not had any restrictions at all as far as network goes. And so it depends, Brian. If you're out there, I'm sure certainly it's something you have to consider. We are so blessed here in the Philadelphia area. I mean, we've got so many options. Jefferson, excellent facility is one example, and we can move around within those, even within the Advantage plans. And I'm using the United Healthcare of AARP. Years ago, I remember asking the financial counselor, and they said, steer clear of that. This is now 28 years later, so certainly things have changed. But when I asked this time, they said, no, there's no problem with that. And so far, my experience has been very positive, tremendous savings versus last year when I was using a well-branded Blue Cross Blue Shield Advantage program. And I'm saving half of that now, especially not paying any premiums every month. So yes, it all depends on so many factors you're talking about, Brenda. But here in the Philadelphia area, wow, are we blessed? You better count those blessings. And Angel and Bert, so many people know that. Steve certainly does. So good points.
I'll tell you, this is the first year that now he's 26 years liver and only 4 years kidney. But we've always had me working. Well, this year I go to Medicare. So let me tell you about the in-service I've had with every department on the phone about, okay, what do we do now? Because now finally Medicare Part B, the DMG, the durable medical equipment, has to pay for his anti-rejection medicine. Now you want to put something else on top of that? He can only use brand. His doctors have deemed he cannot use generic. So we had such a problem after the kidney was, after I gave him a kidney, over Hahnemann, the pharmaceuticals were saying to us, the doctors, oh, Medicare is going to have no problems with you. I said, oh, no, you don't know. I'm a nurse. I'm a nurse too. So we went tit for tat for a long time on this. So now, I'm listening to everything you're saying, but I'm also have learned over the last 4 years since he was a kidney recipient that this is a whole new ball game when you throw in brand. So now this is the first time as of September, both of us have A, B, G, D supplement, this, that. We haven't gotten Prograf yet. His Prograf isn't due yet because we usually get a 3-month supply, and it's going to happen in the next month. I mean, October, November, December. So come January, if we have this next meeting again, I'll let you know well because it's going to be fun, and they're going to hear. And Bill knows, and Jim knows, and Susan knows me. You're not going to mess with me if I can't get brand for him. So, and here's another thing, Brenda, you should know about with Medicare people or Medicare for transplant people. Bert's transplant was done in Florida. He's a liver recipient from Florida, Miami. So now when we go back to Florida, they say, okay, what's your coverage you have? So we had, for my work, I had point of service, I had POS2, I carried for years, full-time nurse. Then we had A, then we had B, then we had G, and oh, no, your Medicare is primary. No, it's not primary. So, so
Yes, I'm still going through that, yes.
Yes.
They think because you have Medicare on file, it's automatically primary, and it really is, it just is.
Yep. And because I had that primary Aetna for all those years for him, they covered his then Aetna turns around and says, we need to have a review board. You can't carry his, they can't pay his brand medicine. Hey, you know what? Review all you want. Go ahead. They had six
Wow.
hepatologist review board from all around the nation review and said, this man can never be on generic because he went into rejection as soon as they put him on. Bert being a nice guy, him being a nice guy, said, you know what, I'll try it. I don't want anybody to mess up my wife's insurance, the work, the people, A, B, Medicare, all that stuff. He said, I'll try it. Put him in rejection. That was in 2014. So ever since then, we play this game. We play this game all the time. So I'm waiting for December. December should be fun.
Yeah, that's interesting you should say that, because the coordinators they still go through that. Somebody has been transplanted for years, and then when they go to get a refill, they want to ask us again, did Medicare pay for the transplant? I mean, come on now, it's on file. He's been getting the med for 5 years. Now you want to tell me it's denied because of B versus D? We go through it all the time still.
Yeah, I had that problem. I'm a kidney pancreas transplant. I was not on dialysis. I was not on Medicare until I aged into it a year plus ago. And when I first got on it, they told me and my to get what I needed from my doctors. But then when the year was up and I ordered medicine, I could not get my transplant meds. I mean, I fought for over a month. Fought till I had 1 day supply. And I got a local pharmacist to help me, because even Medicare, whom I called, said, "Oh no, you're a kidney recipient. B has to pay for it." And I'd say, "No,
not so."
My transplant was not covered by Medicare. I had private insurance, and I could not get it paid, and I couldn't get anybody to tell me how to get it straight. Finally, the local CVS, who I was not buying from, I called them and I said, "What can I get from you? What can you do for me?" She straightened me out.
Oh, wow. That was.
So I was using Blue Cross's, by mail, because I would get, 3 months for the cost of 2, blah, blah, blah. And they kept denying me. They didn't tell me why. They said, we can't do it. They didn't tell me, oh, you need this letter from your doctor.
Yep.
And then when we get it, we're going to ask for it. We're going to automatically reject that letter and ask for a second letter. It was literally unbelievable.
That's how I felt.
Where were you transplanted?
At Penn.
Yeah, you should always be your coordinator. Always.
I spoke to the coordinator. They said, you got to work it out with your insurance company. I really didn't get any help, except from my local CVS pharmacy, who didn't know me from Adam.
Oh my.
So I still get my transplant meds from the CVS. Screw the mailing company. They ask me about it every now and then. I said, "You're really kidding, right?" So beware. Now supposedly my letter said lifetime. Originally the letter said 1 year. So that's why in March of this year, I was no longer able to get get D to cover it like they're supposed to. It was a nightmare.
And this really underscores the emphasis to be your own best advocate, right? And if you can't find the answers, keep searching. Go to your transplant team, go to other people. You just got to keep after it. Unfortunately, right, Brenda?
Unfortunately, yeah. We're lucky.
Him what he's got.
Pharmacist on staff. Yeah, we have a transplant pharmacist on staff who helps patients in situations like that as well. But she works very well with the post-transplant coordinators. But we do not allow our patients to do the legwork for getting their meds. We just don't. So if you have a pharmacist with the transplant team, and you should probably request to be moved over to another coordinator, because you absolutely should not be doing this on your own.
The only thing the coordinator was concerned about was I said that I'm lining up with all my transplant friends if I can borrow some meds until I get this straightened out. Oh, no, you can't do that. That's the only thing she was concerned about.
Yeah, and that's when you say, I need to talk to your supervisor and
No, No,
Yeah.
I kept telling the people who work for my insurance company, I said, I want your name because when the EMTs pick me up and take me to the hospital, I'm reporting you.
Yeah.
How about
They
it?
still denied me.
No, technically, Susan, did you have Medicare when you were transplanted?
No, I was never on dialysis.
No, you don't have to be on dialysis because Bert was on.
You were entitled to the Medicare.
Yeah,
That's what I'm
Bert
trying to-
Bert has been on A and B Medicare since 1983, since his liver disease started. Because
Mhm.
like Bill, someone said to us, look, you've been sick so much, you need to get on Social Security disability. And he got put in
I
1983.
wasn't disabled. I
Oh,
wasn't.
Susan, in your
worked-
case, what we do, in
No, no,
your
wait,
case,
no. In my case, I had company paid medical
Right.
insurance.
Right.
So it was no money
Right.
out of my pocket. And I literally worked until the day before my transplant.
Okay.
Mhm.
So
Yeah, we have lots of patients who never start dialysis either, but they are entitled to the
But
Medicare
you are
benefit
entitled, yeah. Because
the
that's
month
why
of transplant.
yeah, he's been on Medicare since A and B, Part A and Part B since 1983. He wasn't transplanted until 1995. And that's
Mhm.
also the same thing they said to him, oh, you never went on dialysis. And I would say to him, I don't care. He's been on Medicare
Right.
A and B since 83.
Blue Cross paid my $1 million bill. I still have it.
And what's crazy are these waiting periods, right? I mean, who
Yeah.
thinks this stuff up?
Yeah,
Well, he was.
that is quite insane. Yeah, you're entitled to the Medicare benefit, but you have to wait 24 months to get the coverage.
Yeah.
That's total insanity.
Mhm.
I
Yeah, you
feel
could
very
be dead
blessed.
by
I was
then.
on my wife's insurance and I still
Mhm.
am.
Mhm.
So that
Mhm.
24 months didn't mean anything to me because she's
Right.
working and I'm on her insurance.
Right.
And then when it
Mhm.
came up that I'm now eligible for Medicare and I selected A and I read enough to say I don't have to select B and there will be no penalty
Mhm.
until
Right.
she's no longer working and then I have to choose B.
Mhm.
But it's very confusing. And, not just Medicare, all insurance companies are looking for ways not to pay.
To pay, exactly.
They
Don't I say that all the
don't
time?
want to pay. And if they can save
They're in
money,
the
that's their
business to
goal.
not pay. Yes,
Here,
they're in the
I
business
haven't-
to not pay claims.
I have another unique, Brenda, because you're a Medicare person, you would appreciate this. Bert and I and everyone who knows us was involved last year in a horrific motor vehicle accident. So I've been out of work since the accident. So they put me on short-term disability, long-term disability. Now I turn 65 while this happens. So then they go, okay, we're putting you on Part A. Now we're going to put you on, then my 66 and 2 comes along. So I said, okay, you're going to retire. We'll put you on we want you to pick up Part B and we want you to retire. I said, no, I'm on disability.
Here's a result from the web.
I'm on disability. So they said, okay,
Yeah.
we want you to apply for Social Security disability. I said, I'm already on long-term
Already did it.
disability. So just to make the insurance people, here's another, how Brian's saying with the insurance people, just to make the insurance people happy, I go to, naturally we have an involved lawyer who knows what he's doing. He goes, apply. Well, they deny me. They don't want to give me they don't want to give me Social Security disability. You know why? Because I'm of retirement age. Well, here's the thing. I want to get better and go back to work. I don't want to retire. I have no plans to retire. The only reason I'm out of work is because of this accident. So now that's where we're stuck. So I dropped my work insurance and put me over on Medic, and they're like going crazy. They're going to live it. They're going to live it. I get a letter every other week in the mail saying, we want to apply for retirement. And I'm like, it ain't happening. It's not happening. Well, you're already on Medicare. So what? Plenty of people
Right.
who work until they're 75 are on Medicare. So
Very
I
true.
got them. Between him and me, Medicare is really.
So we're going to rename this medical insurance the magic shell game, right?
You just pick up a shell and decide what's under there, and then whatever's under there you
Yeah.
get.
Hey, so does
Yeah.
anybody else have any questions about their coverage for Brenda or Juliet? Well, listen, I want to thank you both so very much for joining us this evening in this very informative presentation, and we hope to have you back join us next time.
Thank you.
Perfect.
Thank you
Thank you
for
for having
having
us.
us. It was a
Thank you.
pleasure.
Very nice meeting you, ladies.